Okay, so without further ado, Mike, I'll hand over to you for our first session.
Thanks very much, Tom. And can I echo Tom's greeting? We're delighted to see as many people attending this as we are seeing at the moment. This is a session facilitated by the Joint Royal Colleges of Physicians Training Board, or the JRCPTB for short. What we're trying to do is give people an idea of how we see trainees progressing and how we're facilitating that progression as much as possible. We all know, of course, that COVID has had a significant effect on training, and I think it's fair to say that it's affected all involved, either trainees or trainers. The effect, however, is a bit variable. Simply geographic basis of where people are studying or working has had a very significant effect. Those working in London, probably, it's fair to say, have been hit hardest, but there is no doubt that everybody has seen a very significant amount of COVID coming into the acute hospitals. But the personal effects of COVID are, of course, variable as well. People may have had the illness, the stresses and strains of working in COVID wards or in hospitals where there are a significant number of very sick patients, where we're having to look after many, but also seeing a very significant number experiencing end of life. That's had a very significant effect on people's mental health, and the stresses and strains, I think, have been very well documented across many working within the NHS. But we also recognise that there has been compromised access to training and assessment opportunities, although we have tried to encourage as much of this as we can, especially looking at how people are functioning within the COVID wards and trying to recognise the training in the management of patients that's still present in COVID wards, and indeed the ability to achieve workplace-based assessments. So what have we done to try and make sure that progression in training is easy as possible, can be facilitated for trainees, but also keeping a very significant eye on maintaining patient safety? Over the last few months, we've tried to keep it in touch with all the training program directors across specialties for them to indicate how many of their trainees, in terms of percentage, may require extensions to their training programs. This has resulted in very variable, again, results, and it is becoming increasingly apparent that the real indicator of the numbers that will require extensions will be the ARCP process, which we're just on the margins of. But prior to ARCPs, we have tried to ensure that people are able to show their capabilities and competence in areas where perhaps their exposure and learning experiences have been modified. Certainly for the ACAT 2020, which has replaced the previous ACAT, we've introduced more components of the expected requirements for a registrar, so that we are identifying more readily some of the generic capabilities that have been up till now really quite difficult to assess. We know also that the experience in outpatients and practical procedures has been severely compromised. For the first of those, we've introduced the Outpatient Care Assessment Tool, or OPCAT for short. We are still looking for one that has a T at the front to get a TopCat assessment, but at the moment we've got stuck with OPCAT. But this is not a mandated assessment. What we're doing is recommending it because we know that the numbers of outpatient clinics have decreased very significantly, and we need to be sure that trainees are getting some experience and that that can be assessed in that environment. This works for both virtual consultations and face-to-face. We've provided increasing flexibility in the decision aids, and last year we had quite a lot of flexibility introduced, and that is being reproduced this year. But for some specialties, The continuance of the pandemic has meant that there are specific points where core capabilities have to be achieved before progression, and included in this are cardiology and dermatology. But modifications to the curriculum have to be agreed with the GMC, and we've been to the GMC to show the modified decision aids, and indeed in internal medicine there have been specific derogations sought. The learning opportunities in internal medicine stage 1 have been recognised as giving experience in terms of critical care of patients and in elderly care obtained in COVID wards without necessarily getting specific experience in what would be specified care of the elderly wards or indeed specified critical care environments prior to the pandemic. The outpatient experience I've already mentioned, and we have modified the numbers required within the internal medicine curriculum. The temporary derogations for internal medicine have also been modified when it comes to MRCP. We have enabled progression through training without MRCP, and that will continue to be the case for the foreseeable future until trainees reach an ST4 post. No trainee will be able to progress beyond or into an ST4 post without full membership. This is recognized by the membership department of the Federation, and we are trying to ensure that adequate opportunities to take each part of the exam are available for trainees in UK training programs. If the failure to achieve MRCP is COVID related, then at the the end of an ST3 program, they would be given a 10.2 outcome. If the failure to achieve is not COVID related, then the outcome would be an outcome 3. The ALS certificate has caused some great problems and concern because of the inability to undertake an ALS course. And we've basically said that this certificate is not required for progression or indeed getting to CCT, but anybody progressing beyond CCT should ensure that their employees know about the lack of an ALS certificate so that the employees themselves can judge whether such a piece of paper is required. And the issue as regards management competencies and courses, we are looking more for experience in COVID or other roles that can be recognized so that people can still progress without undertaking a specific course. Other areas where we've sought derogation are the practical procedures. It's become increasingly apparent that those in internal medicine training are unable to get all the practical procedures signed off. We have therefore ensured that trainees can progress into the 3rd year of internal medicine training or indeed into an ST3 of a Group 2 specialty without acquiring all the practical procedures competencies that would previously been required at the end of internal medicine year 2. There is, however, a differential now in that those entering internal medicine year 3 will have to get to the required level of competency by the end of internal medicine training stage 1. But those entering ST3 in the Group 2 specialties should discuss with their educational supervisor which procedural skills are required for the specialties, because it may not be necessary to gain competencies in all the procedures. For instance, those going into medical oncology or hematology may require the ability to do pleural aspiration. But this is an important discussion that again needs to be had with your educational supervisor as you progress into these specialties. We have provided detail of the higher specialty curricular derogations on the page that's shown on the JRC-PTB website. For cardiology, I've already mentioned that there is now a critical progression point at the end of core cardiology training, that is the end of ST5, where there will need to be a review of which practical procedures especially still need to be brought up to the level that allows a trainee to move on to the more advanced parts of the cardiology curriculum. Such a critical progression point also is required at the end of ST4 for dermatology, and in gastroenterology, JAG accreditation would usually be required by the end of ST4. This will be subject to review by each ARCP panel, but these are the guidance areas that are being given, and others are seen for GUN and immunology. The exam requirements I've mentioned for membership, but SCEs still remain an absolute requirement to achieve CCT, as are the completion of the curricular competencies that have been outlined throughout all the higher specialty training curricula. The guidance that we have delivered has been published on our site under core training and a higher specialty training. I suggest that you look at these pages for further information, because to try and get through all the information that's there would take the whole of this particular webinar. But we have other information that we want to share with you, and for that reason, I will now hand over to Alistair Miller.
Great, thanks Mike, and thanks to Tom for facilitating this webinar. Okay, so Mike set the scene as to what's happened in the background from the perspective of training in relation to COVID. What I'm going to do is talk about how you as trainers and trainees need to prepare for your upcoming ARCPs. And the first thing to say is a lot hasn't changed. The critical thing is for you to plan well in advance and talk, meet and communicate. So educational supervisors and clinical supervisors need to be regularly meeting with their trainees and discussing their strategy for ensuring that the ARCP process runs smoothly. For many years, ever since we really moved into the era of competency-based medical education, the role of the educational supervisor report, the ESR, has been completely critical for people's progression through the ARCP. So you've got the ESR written by the educational supervisor, shared with the trainee prior to ARCP, and all the various clinical supervisor reports through the multiple consultant report system will feed into this, as will other data from workplace-based assessments, including stuff like the MSF and individual structured learning events, etc., will all feed in to the educational supervisor's report. But his or her synthesis of all the information is going to be critical. Despite COVID, and in every situation before and after COVID, the main aim of the ARCP is that most trainees should be getting an outcome 1. And this is because we know that the vast majority of trainees will and are progressing in line with the basic curriculum. Non-standard outcomes, as they're called, i.e. outcomes 2 and 3, they're not a punitive an assessment. They do not mean that anybody has failed. They just mean that the trainee is not yet ready to progress, or if that will be an outcome 3, or if they are ready to progress, there are some things outstanding that they need to catch on in the following year, which would be an outcome 2. So unless you as an educational supervisor, or unless the ARCP panel identifies real issues of patient safety, or issues of trainee safety, in other words, that the trainee is going to be put under such pressure in the ensuing year to catch up, that that's going to be injurious for their own safety or mental health. So unless that is the situation, by and large, the ARCP should be issuing a standard outcome 1, meaning that the trainee just progresses. If it's not an outcome 1, then the algorithm goes in your mind that the first question is additional time required to catch up? So are they going to have to spend some more time in the current training year? Or can they progress, but with some caveats saying they need to get a bit more experience here or to be assessed more closely in a particular capability. So if they require additional timing, then that's an outcome 3. If they're just allowed to progress under normal circumstances, that's an outcome 2. COVID has slightly complicated the situation because it was felt that even though, as I've said, all trainers and trainees need to be aware that outcomes 2 and 3 are not failures, they're just non-standard. But despite that, it was still felt necessary to introduce outcomes 10.1 and 10.2, which are the COVID equivalents of outcome 2 and outcome 3. So in other words, if it is felt that somebody's failure to get a standard outcome is due to COVID, if they need additional timing, they get an outcome 10.2. If they do not need additional time, but there are certain deficiencies which can be made up in the ensuing year, then they get an outcome 10.1. So if you like, an outcome 10.1 is the COVID equivalent, COVID-related equivalent of an outcome 2, and a 10.2 is the COVID-related equivalent of an outcome 3. So I think we all know that in the past, people were assessed just on the length of time they'd been in a program, and as long as they were doing okay, you just tick them off and said, yes, they're fully competent and can go on to the next stage. And then we shifted from that to the very atomized view of life that we could divide competencies down into these individual competencies, like saying this trainee can look after heart failure, but they can't look after pneumonia, or this trainee can look after a rash, but they can't look after a fever. And clearly that sort of distinction was very artificial and not really educationally valid. So we've evolved from that into the era of capabilities. So we're saying things now like this trainee is capable of doing a post-tape acute ward round, or this trainee is capable of running a multidisciplinary team meeting. And of course, as you well know, we give different levels of untrustability to the trainee when we're making those assessments. So it's a much more holistic assessment than it used to be with the old tick box competency model. So the IMT curriculum, the new curriculum that everybody will be on now, apart from a few people who may still have completed core training, but the vast majority of people are now on the internal medicine curriculum and are doing internal medicine stage 1. And this has mandated specific experiences that weren't in the core medical training curriculum. So people now have to do a certain number of clinics, have to spend a specific time on critical care, and have to spend a specific time doing geriatrics. As Mike has pointed out, the COVID pandemic has meant that some trainees, not all, but some trainees have found it difficult to achieve all these mandated experiences. So as we've heard from Mike, many of them have been relaxed. The requirement to actually have those specific experiences has been relaxed by the GMC derogations from the normal curriculum. So if we're going to relax on the specific experiences, we have to rely even more heavily on the capabilities in practice. And again, Mike's referred to the various forms that are now in use. So to see if somebody's capable of doing outpatient clinics, rather than just count the number of clinics they've done, we should rely much more heavily on multiple consultant reports from a consultant who's been specifically supervising the trainee in the clinic, and particularly by using the new OPCAT tool. And what we're saying is, has the trainee achieved an appropriate level of SIP4, that's the outpatient-based capability in practice, irrespective of how many clinics they have attended. And similarly in critical care, have they achieved the appropriate level in SIP7, which is largely based on the deteriorating and acutely ill patient. And in geriatrics, have they achieve the equivalent capabilities in particularly SIP 6 and 8, which are related to elderly care type capabilities. So we're looking for capability, not specific numbers of experiences. And this term gap analysis has emerged, and 10 years ago, none of us had ever heard of gap analysis, and now we talk about it every day. And what it is, it's looking at the gap between what a trainee should have by way of experience, capabilities, knowledge, skills, attitudes, etc., at this particular stage of their training, and comparing that with the actual experience, capabilities, etc., that they actually have. And that is the gap. That's the gap between where they should be and where they actually are. And hopefully for most trainees, it won't be a very large gap. But where it is a significant gap, then the trainee and the trainer in consultation need to produce an action plan to close that gap. And if it can be closed within the training time available, that's great. If it can't, then the trainee may need additional training time. And that gap analysis is done by the educational supervisor, and on the basis of that, they then complete the educational supervisor's report, and that goes to the ARCP. And now I'll hand over to David to talk about the ARCP process itself. Thank you.
Thank you very much, Alistair. And again, thanks to Tom for setting up this evening's webinar. I suppose the first thing to say is we could not have worked out our timing worse than having a pandemic. So we were in the midst of the implementation of a new IM Stage 1 curriculum with the first intake in 2019, as we all know. And of course, the pandemic has really destroyed a lot of the initial thought processes we had about the structures that Alistair has just alluded to in terms of the new requirements for geriatric medicine, critical care, outpatient experience, which were embedded in Stage 1 curriculum.
David, you're muted.
Has that solved the problem? Can people?
Yep. Yes, that's worked, David.
Thank you. Sorry, it's a very old Mac I'm working on, and I'm having a bit of problems. So, as I was saying before, I was rudely interrupted by my microphone. We have two processes going on just now. So we have an issue with Stage 1 training, which is embedded with the SIPs, which has been alluded to by Alistair. But we still have Stage 2 training, whereby we haven't quite evolved into the SIP process. So I'm going to concentrate the first few slides here upon the Stage 1 training and how the assessment at ARCP will happen. So how do we assess in the Stage 1 panel? Well, we use the educational supervisor's report as the most important piece of information, and the explicit requirement there is that the educational supervisor has utilised all of the information which is available from the portfolio, which should have been uploaded. And obviously there have been derogations, as we've heard from Mike earlier in the talk. However, the derogations that we have, we still have a guide as to what we would require as pretty much a bare minimum. So we do feel still that for Stage 1 training there should be no fewer than 4 SLEs. Because we can't really make any holistic gauge judgment on a trainee without any evidence. So we'd be quite keen that the ACAT 2020 was used, and at least 2 ACAT 2020s were used for the assessment process. And as Mike has said, we now have the OPCAT available to assess SIP4, the outpatient experience. And whilst that's not mandated by GMC, we're strongly advising trainees to use the OPCAT to back up that information. In terms of CBDs and mini-KEXs, they probably have dropped down the pecking order a little bit. We're delighted to see them and use them in ARCPs, but I think the ACATs are particularly important. MCRs equally are extremely important, and we're very keen, because of the issues about assessing unselected take, particularly at the end of stage 2, that at least 3 MCRs are completed by consultants who work with a trainee on the unselected take in the acute medical units. The MCRs can also be used by trainees who are working with consultants in an outpatient setting, and the MCR can comment again on the ability of the trainee to run an outpatient and manage outpatients, particularly for those with long-term conditions and so on. As regards the MSF, which has always been a very important workplace-based assessment, again, we would ideally like to have 12 sources for a completed MCF, but if a trainee is unable to complete an MSF and does not achieve the full 12 sources, the educational supervisor should state a reason behind that. And obviously COVID has had a major impact on the ability to achieve assessors for MSFs. With regards to the rotations, derogations have been mentioned. So the time spent in critical care, geriatrics or palliative medicine is much less important than now the SIPs that demonstrate that the abilities and capabilities have been achieved. So I'll move forward. So in terms of the derogations that we've got in IM stage 1, we've heard a little about the stage 2 derogations and the specialty specific issues which Mike has mentioned. The key thing here is about a holistic approach. So the ESR has to look at the training environment and the training experience for an individual trainee in a holistic way. And similarly, the ARCP panel must take a similar holistic approach. So we're very keen that we reduce this tick box exercise and remove the requirement for huge numbers of linkages. And we're not mandating linkages in this ARCP season. With regards to the competencies, we have decision aids which outline the competencies and capabilities which trainees should achieve and should aim to achieve, but we're taking away defined numbers. And we're similarly taking away the requirement for things like quality improvement projects. ALS has been mentioned by Mike already. It does not prevent progression, failing to have an updated ALS certificate. And again, Mike has mentioned about the MRCP situation in terms of progression and the requirement to have full MRCP really by the end of ST3 now. The derogations in regards procedures, Mike has mentioned, and I stress the importance of outpatient clinics. We are not stating any minimum number of outpatient clinics. It's all down to the use of the OPCAT and the use of the MCR to demonstrate that the capability has been achieved. So the original requirement for outpatients had said indicative 80. All the surveys which have been performed, both in HE through Phil and in Scotland, have identified that trainees' greatest concerns in stage 1 are achieving outpatient numbers because of the effects of the pandemic. And that we really don't feel we can be absolutely requiring numbers this year. People should still try to achieve as many clinics as they can, and we do think that 20 clinics in a year is a reasonable number to achieve, but the numbers game is not required here. And as I already said, OPCATs are not mandatory. They've not been mandated by GMC, but we strongly advise trainees to use the OPCAT and the MCRs. Logbooks are increasingly being used by trainees, and I think we should be pushing for this more as time goes on, but it's not an absolute requirement, it's a recommendation. So we're probably all aware of the outcomes which have been established in the standard outcomes for many years, the outcomes 1 to 5. And in the last 12 months, we've had the outcomes 10.1, 10.2. We've already heard the requirements for 10.1, 10.2 from Alistair, and the equivalent of a 10.1 being pretty much an outcome 2, but with COVID reasons, whereas a 10.2 is much more like an outcome 3, but again due directly to the effects of COVID. So specific issues with stage 1 training, those trainees who had in the last 12 months achieved a 10.1 outcome at August last year and are now sitting in the position of moving into IM3, we absolutely need these trainees to catch up with MRCP. So engagement with MRCP is important. And if we see trainees entering IM3 who have made no attempt to sit MRCP examination, and it's non-COVID related, it's a failure to engage with the process, then obviously we'd be looking at an outcome 3 in that category. Whereas if the inability to move forward is because there's been no ability to actually get onto an MRCP examination and actually sit the exam, then it would be a 10.1. Procedural skills have been mentioned by Mike already. And the important assessment for IM3s, trainees moving into IM3, is that they are capable to manage the acute unselected take, SIP1 in other words. And the ARCP will concentrate considerably on the evidence that shows that level 3 capability of SIP1 has been achieved. Okay. There are some resources available again in the website which outline the decision aids, the ARCP guidance, and the checklists. And I would point everyone to the stage 1 rough guide, which has been recently updated. And at that point, I think I'll pass on to Phil, who's going to take us through further ARCP after the stage 1 outcomes.
Okay, thank you very much, David, and thank you very much, Tom. The following slides really talk about IM stage 1. However, within them, there is also information which will be useful for trainees at other stages of their training, and I'll try and point out those areas as we go through. I'm Dr. Phil Bright. I'm the HEE Clinical Advisor for Internal Medicine and Head of School of Medicine in the West Midlands. First of all, just to orientate people in time, we're now mid-May. ARCPs tend to happen, 20% of ARCPs happen in May. The remaining 80% happen roughly equally divided into June and July, with most being completed by start of 3rd week of July. From the ARCPs this year, all trainees should have a very detailed plan if they're not getting a outcome 1 or an outcome 6 if at the end of training. It should be a much more detailed plan than have been previously used in ARCP outcomes. And should trainees be getting an outcome 10.1, a 10.2, or an outcome 2 or an outcome 3, there should be clearly indicated when a subsequent ARCP, in the case of a 3 or 10.2, or an IRCP should happen. Having had your ARCP, all trainees should now be offered a discussion with someone, the most appropriate person following the ARCP, to discuss the outcome with them. Usually, if it's a 10.2 or a 3, and in some cases, if it's a 10.1, that should be with a member of the ARCP panel who awarded the outcome. In other cases, it may be with your current educational supervisor. And those discussions should happen before you move on to the next stage of training. In early August, you should then be meeting with your next educational supervisor, who will then take over and manage the training for the next academic year. And for most people, they will have a follow-up ARCP or an interim review towards mid or end of the autumn. And for most, if you're on additional training time, it should only be for a few months. And we need to think about the reasons that people might get additional training time. In the past, additional training time on an outcome 3 has often been given for trainees who have not been able, for various reasons, to engage with the training system. This year, the situation may well be the reverse of that, in that trainees have been very willing or able to engage with the training system, but the training system hasn't been available for them to engage with. So there will be a difference in approach to the way extensions are managed. And currently, the SEBs, the statutory education bodies, are thinking very closely about how to make sure that people regain their training position as rapidly as possible. Now, just to think about those ARCP outcomes that have been previously mentioned, for those trainees looking to move from year 1 into year 2, there are really just 3 main outcomes. An outcome 1, progressing okay, and outcome 2, issues not addressed but not due to COVID, and an outcome 10.1, where there are issues mainly down to COVID. Those trainees who are leaving stage 2 can go on 2 paths. They could move on into IM year 3, and we suspect that 90% or more will do so. Or they could actually leave IMT training and take up a group 2 specialty if they've been appointed to one. Trainees in this category may get an outcome 1, an outcome 2, a 10.1, a 10.2, or an outcome 3. With a 10.2 really being reserved here for trainees where it is considered that the time that they would have in an additional training year in IM year 3 would place them under unfair burden, and it's actually better to have an extension at this stage than to progress. And that would be very much an individual assessment based on the trainee's circumstances and what they have to do to catch up. So the post-ARCP discussion that all trainees should have should go through the reasons for the ARCP outcome. What were the factors taken into account? There should be some recommendations made and the timescale for that catch-up, which will then go on to inform an outlined training recovery plan. And that you should have a clear indication of when your next ARCP or interim review is going to be, at least down to the month in which it will take place. Next stage of training is your induction meeting with your ES. And to this meeting, you should really take the training recovery plan with you. And this is true for all trainees of whatever grade. So an appreciation in that meeting between yourself and your educational supervisor about what was missed last year, what was done last year, and what needs to be done to catch up, and how that can be supported. So coming out of that meeting, you need a very clear idea of what the forthcoming year is going to look like and how you will meet those requirements. You should also set out how often you're going to meet with your supervisor, and currently we're urging that this should be a face-to-face contact time at approximately 1 month. That training strategy is one of the most important documents to be developed and looked at in those face-to-face contact time meetings. And it will give the supervisor the evidence they need to write the end of year report. Particularly for the MRCP, it's important to consider what parts are needed, when you're planning to sit it, how you're going to prepare for it, and what support you will need to get a successful pass. And it is good practice to not skip that stage and just wing it, basically. It's very important to actually set out a plan and to stick to that plan if at all possible. Thinking of the experience, what have you lacking? What were you able to get during the pandemic, and how can that be evidenced? Are you missing placements? Are you missing critical care experience that can't be evidenced by what you've done in the pandemic, or you want to get better at? So do you need a placement to meet those curriculum outcomes? The procedures issue is quite important. For those moving into IM Year 3, you need to have a conversation both with your ES and to alert the trust that you're in about any skills that they would normally expect a medical registrar to have, but which you may not have achieved because of the pandemic. And they should be putting in arrangements for cover should you be on call as a medical registrar and required to do one of those procedures, someone else should be available for you to do it until you have been signed off as being capable of doing so. For those moving into a Group 2 specialty, it's a conversation with your ES or training program director about which of the procedural skills that you haven't achieved are actually appropriate and still need to be achieved for the curriculum that you're now working in. And it doesn't mean that you have to sign off all missing procedural skills. The CIPs we've already discussed. CIP is particularly important to ensure that you're med-reg ready. And should it be that there is some doubt, the initial part of an IM Year 3 can be adapted so that you're only doing medical registrar during the day when there's plenty of support around until you and your trainers feel confident that you're at the right level. Think carefully about CIP4 and outpatients and how you can regain the experience necessary to demonstrate the curriculum outcomes. It's not about numbers. Numbers are guides. And also think carefully about how you get necessary experience around end-of-life care and how that can be achieved in the coming year. Trainees leaving to take up a Group 2 post. To take up the post must have MRCP Part 1. So if you leave without it, you cannot take up your Group 2 post. And again, as I've said previously, discuss with your ES or TPD what procedures you actually need, if any are missing, and think about how you can plan to catch up on those. So just going back to that timeline again, we're in May now. By the end of the autumn, the hope is that most people will have caught up. And if you're not catching up, then additional interventions may need to be put in place to help you catch up to the training position that you should have been in without the pandemic. Good ideas about how to catch up. Many trusts are now using clinic blocks where people will be allocated to do outpatient clinics in a concentrated way over a period of time, hopefully being freed of their ward duties. So we're actively talking to trusts to try and make that happen. Simulation sessions may be appropriate, but are not the panacea to everything. Think carefully about how to use study leave appropriately, and HEE and the other SEBs will support you in that. Make sure you do meet your ES regularly and get the necessary support. You're not in this alone. It is a journey for the two of you to take over the next academic year. Update your training plan regularly, redirect it, refine it, change it. Identify obstacles, things that aren't happening, and seek to address them. So if you're not being released from duties and because of that you aren't able to regain your training experiences, discuss that and see if you can work around it. Keep in touch with your TPD and then raise any difficulties that aren't being resolved with them. Thank you.
Thank you, Phil, and thank you everyone for your presentations today. Firstly, I'd like to apologise to anybody who had any difficulties trying to access this webinar. We did have some technical difficulties at the beginning, which then were resolved. So I'm really sorry for people who have missed the beginning. This webinar has been recorded, and the recording will be available on the JRC PTB website shortly following the webinar. But now what we'd like to do is open the sort of the floor or the chat box, should I say, to any further questions as they come in. And what we've been doing as the speakers have been presenting is collating those together. So Zoe, have we got our first question?
Yes, sure. So actually, I'm going to go to one of the last questions we had just because it relates to something that Phil was talking about. Someone's asked what's the advantage of face-to-face meetings over meeting on Teams, and that they found Teams more flexible and convenient. I presume by face-to-face that could be virtual. Is that right, Phil?
Yeah, some people really prefer face-to-face meetings, and there's a lot in that human interaction that people gain benefit from. So although functionally it can be delivered virtually, many people do prefer to have it as a face-to-face meeting, but either is acceptable. I was just using it really as shorthand to make sure it was a one-to-one meeting rather than necessarily a face-to-face meeting.
Okay, thank you, Phil. So there were a few questions earlier on, so I'll just start with one an ST4 trainee who was advised due to health reasons not to do nights. Will that affect their training? Do you have any advice for that trainee? Mike, would you like to answer that one?
Yeah, there should be no problems. This is about looking at learning outcomes. You have to show that the curricular experiences and learning outcomes have been achieved. If your educational supervisor is content with the arrangement that you are getting an adequate experience of the curricular requirements and that you are progressing with those curricular requirements, there is nothing that says specifically about out-of-hours work. Of course, there are some advantages to out-of-hours work in terms of experience and working in that environment, but if you are not able to do that, then there should be nothing to stop you progressing because of the hours that you are able to work. Is based around the capabilities that you require during a learning experience.
Great, thank you, Mike. There were a few questions about outpatient clinics. So the first one is, will the cumulative number of outpatient clinics as defined in the decision aid still be required by the end of IM Year 3? David, would you be able to answer that one?
Yeah, I'm happy to take that. The numbers game is, as Phil has said, we're no longer in a numbers game. It's about capabilities. So there is an indicative indication of the number of clinics that we would expect a trainee to try and attempt to see and attend, but there is no number counting going on. So it's about demonstrating the capability. And there has been another question about using OPCATs to replace workplace-based assessments. Well, I've mentioned in the talk that there are certain workplace-based assessments which we absolutely require, so the MCRs, the MSF, etc. OPCATs are not mandatory, but I wouldn't be advising them to be used as a replacement for those core essential workplace-based assessments. They're extremely helpful to give additional information to the educational supervisor and subsequently to the ARCP panel that you're showing capability in SIP 4.
Thanks, David. And while we're on clinics, I don't know if you could help as well with or Phil actually might be better with this one. Many clinics are now being done over the phone, therefore there's less exposure to clinical examinations. Will that be taken into account at the ARCPs?
So the learning objectives from clinics for internal medicine stage 1 trainees is all about how to perform in the outpatient environment, not necessarily the demonstration of the clinical skills in the outpatient environment. It is good if you can, but it's more about the conduct of yourself within the outpatient environment, taking the GP letter, discussing with the patient, formulating a plan, and sending a letter back to the GP or adapting an originally existing plan. So at this stage, it is desirable but not absolutely necessary to have the clinical experience that includes the clinical examination. That can come later on as the system catches up with itself, but I wouldn't be overwhelmingly worried about that. Mike has some points to come in on there.
Absolutely agree with what Phil's saying, but also we can't forget that the physical examination is a critical part of what we do within physician work, and therefore, whilst we are somewhat constrained within the outpatient environment at the moment, and there is a question about whether the OPCAT can be completed by SPRs, the answer to that is yes, as long as they know how to assess and have been appropriately taught as trainers. What we're trying to do is ensure that trainees get an appropriate clinical experience, and much of what can be achieved within the wards is automatically going to be clinical examination. So don't forget, there are a multiplicity of environments in which you can achieve some of the capabilities that we are looking for you to obtain during your training program. So because you can't do an examination automatically in an outpatient clinic, that does not apply within the ward, etc. So we are looking for you to be flexible, as we're trying to be flexible in ensuring you get the relevant learning opportunities fulfilled so that you become truly capable along the lines of the SIPs that exist in the internal medicine training program.
Okay, thank you. We've got quite a few questions coming now. So there's a question about if a trainee was on a 10.1 last year, is there a requirement to catch up on missing things like ACATs or a missing procedure this year? Or will they continue on it on a 10.1?
So at the ARCP, they'll look about what it was that was missing last year, what you've been able to achieve, and what you still need, and that may well be rolled into a further 10.1. If a trainee is at a progression point where it is viewed that the pressure on them would be too great to regain within the remaining training time allowed in the program, then consideration would be given to a 10.2 at this stage. But the usual situation would be rolled into a further 10.1 with the necessary recommendations embedded within that.
Okay, thank you. There was a question about whether MRCP Part 1 is needed to be eligible to take up a Category 2 as a Group 2 specialty. Is it a COVID derogation? It is a COVID derogation. And so, yeah.
The issue for Group 2 specialties, of course, the recruitment required that people had Part 1 to get into a Group 2 specialty this year. Ordinarily, we would have been expecting a bit more than that. Because of the way that the recruitment was running, it did become a mandate to get into ST3 in a Group 2 specialty. But we're trying to be, as I say, as flexible as we can be to try and allow people to progress. One of the biggest concerns, of course, is people going into an ST3 post without any part of membership. There would be a significant stress and pressure to try and get all components of the membership out of the way before they entered ST4. So that always needs to be taken into consideration as well. But because of the way recruitment ran this year, it was necessary for people to have Part 1 to be considered for an ST3 post.
Thank you. There's a question about whether departmental teaching can be counted as local teaching hours. So, for example, could ITU teaching, care of the elderly teaching be counted additionally to the specific IMT teaching? Phil, would you be able to answer that one?
Yeah, so again, it comes back to this. We're no longer practicing curriculum accountancy. It's not about counting things. It's about having teaching which fulfills training needs. So yes, teaching wherever it is can now be considered as helping to achieve the hours goal, but actually the hours goal itself is no longer as important. It's about where a particular trainee is in terms of getting the overall curriculum outcomes.
That's great. And I think that answers another question that someone's asked about shielding who've met the competencies, and would the decision be based on training time or achievement of competencies? It is very much on the achievement of competencies and capabilities rather than time. Someone's asked, just to clarify, 80 outpatient clinics will not be part of the ARCP requirement for IMSI Year 3 next year. That's correct. If a trainee for health reasons was not able to attend face-to-face activities and had to work remotely due to COVID, does this affect the ARCP outcome? I think that's already been answered.
It's also important that a trainee in that situation has a conversation, and it's about how confident do they feel. So can the curriculum outcomes be technically ticked off, but if training in that position is thinking, actually, I really now feel really unconfident, then that needs to be taken into account, because we don't want trainees to be put in a position where they are asked to move up, asked to take on the next stage of training if they absolutely don't feel that they're at the stage, because that will just induce huge amounts of stress.
Great, thank you. There's a question here: if someone isn't successful in getting an ST3 position in a Group 2 specialty this year, do they have to do IMSI Year 3? And if they don't feel that would be particularly helpful to their career, what would their options be? Mike, do you want to answer that?
Yeah, no, they don't have to go on to IMSI 3, but to some extent, it's also maximising the potential. If you leave at the end of IMSI 2 and you don't yet have membership, or if you do have membership, then you are looking at where you're going to go. because at the end of that, you haven't officially completed a core training program, which may have set you up to go elsewhere. You are therefore looking at going into a Group 2 specialty, and as time goes on, there will be other people looking at Group 2 specialties, and you have to bear in mind that you will be competing. So I'm not saying that you have to stay in IMT through to IMY3. Nobody can tell you what you have to do, but it goes back to something Phil's just said. Take advice about your personal circumstances, know what your opportunities are likely to be, and the best person to discuss that with is a clinical supervisor, or preferably your educational supervisor, who can properly advise you about what the restrictions would be in your opportunities if you leave after IMY2 without getting full acknowledgement of completing a core training program.
Great, thank you. I've got a question here. Is MRCP mandatory to proceed to ST4? What happens if an ST3 does not acquire the MRCP? Mike, would you like to answer that?
Yeah, that is a critical decision point. People do have to have membership to progress into ST4. The simple requirement is that people have to have shown that they have adequacy of knowledge to be able to progress, and the membership is that the exam that shows that. If you don't get membership by the end of ST3, you should be offered an extension to training. Depending on the circumstances, that would usually be a 10.2 or a 3 to give you extra time to get the membership out of the way. There is also obviously the possibility of leaving at that point in time, take a time out of training and take another job to allow you to pass membership. But membership at the moment is an absolute requirement to get into an ST4 post.
Great, thank you. There's a question here, should the time in COVID redeployment from a specialty, so going out of your specialty into other medical wards, be recorded as time out of program on Form R? David, are you able to answer that one?
Yeah, again, I think it depends on showing your capabilities within your parent specialty. So if you've had a 2-month or a 3-month period out, are you still achieving the competencies that are required in your parent specialty? If you're not, then there's a direct COVID knock-on effect, and you would record that, and it would be a COVID outcome, which would be recorded in your RP.
Great, thank you. So there's a question here, would an outcome 10.1 or 10.2 affect progression to a Group 2 specialty? Alistair, would you like to answer that one? I'm not sure, I can't hear you, Alistair.
I think Alistair may have left.
Oh, right, okay. Phil, are you able to answer that one?
So you wouldn't be able to progress, I think, into a Group 2 specialty if you had an outcome 10.2. You would be able to progress if you had a 10.1, but Mike might be able to give a clearer answer on that.
No, I absolutely agree, Phil. I think if you've got a 10.2, you're needing, there are specific things that you're needing to achieve, and therefore you wouldn't be able to progress. The 10.1, that automatically is allowing people to progress, but there is something within the required outcomes that still needs a bit of attention, but it's felt that in allowing you to progress to an ST3 post, you should be able to get that sorted out before you get to ST4.
Great, thank you. There's a question about whether an IM Year 2 trainee can progress into IM Year 3 with an MRC Part 1, but not the other parts, if the other parts of the results aren't. So that's a yes, isn't it? Yeah.
Yes, that's an easy yes.
Excellent.
So can I just pick up the point about time out of training? You wouldn't submit that on your Form R if you've not been in your specialty and you've been redeployed. You certainly wouldn't go putting that into your Form R as such.
Great, thank you for that. There's just a question here to say, does this session cover ACCS acute medicine, and how long is the programme? If I could just point you to the JRCPTV website, some specific guidance for ACCS trainees, particularly those in their CT3 year, and how the curriculum's changing. because unfortunately we don't have time to cover that now. It's gone past 7. What do we want to try and finish the last couple of questions? 2 more.
I
Great.
think we should continue with the questions if they've been asked.
Great. So some specialties have suggested that acute/general medicine curriculum requirements could be achieved 6 months of IM Year 3, such that the second 6-month period could be done without acute general medicine experience to allow trainees a chance to gain deeper experience in a specialty. Does the panel think this is acceptable? Anyone want to start?
So IM Year 3 is all about general internal medicine. It's not about training in a specialty, and people should be engaging with general internal medicine throughout their IM Year 3 year. Indeed, we strongly recommend that trainees don't do the specialty within IM Year 3, that is the specialty into which they want to progress the rest of their career. It is much more profitable for them to do a specialty allied perhaps to their main career specialty. So a cardiologist, and I speak as a respiratory physician, would greatly benefit from doing respiratory medicine as a specialty within IM Year 3, or indeed vice versa.
Any other comments?
I'd like to emphasize exactly what Phil's saying. This is about trying to increase the number of generalists who are capable of taking care across a variety of specialty conditions so that they can actually manage patients who almost universally, when they have an exacerbation of their chronic condition, are presenting with multiple comorbidities. That is the population we're serving, and there should be a recognition that we need doctors who are able to treat across the breadth of comorbidities and know when they need a specialist, but manage without getting somebody seen by a whole series of different doctors to take on board relatively simple problems. And that has been part of what we've been seeing within the physician specialties. We need to make sure that patients who have a specific specialty need are seen by specialists. But if we continue to have lots and lots of patients seen by lots and lots of different doctors, it causes confusion and it is not in the best interests of the patient. We're looking to ensure that when patients present to hospital with an acute illness, there is the ability to manage across the different difficulties that patient has, not simply dealing with one problem.
Great, thank you. There's another question here about the exam. So can trainees progress?
David wanted to come in on that.
Oh, sorry, David. Sorry, David, go ahead.
I'm just going to reiterate, I was also going to state that when we were designing the whole concept of the third year, we did say that trainees could have an experience of specialty for 6 months of the year. We divided it deliberately into 2 6-month groups, but that at no time have we said that the 6 months of specialty, in inverted commas, was only specialty. There was an expectation that the trainee would still be involved in general medicine and the acute unselected take, so that the full 12 months was very much an experience of acute medicine and some specialty flavour. And as Phil has said, perhaps that specialty not aligned to that which you were thinking of as your final ST4 definitive higher specialty training programme.
Great, thank you very much. I think probably just this one last question, and then we could point people to the information on the website. So can an IM Year 1 progress into IM Year 2 without Part 1 of the MRCP? I think that's just a yes, isn't it? So that is in the guidance on our website. They can progress into the second year. There's also a question about quality improvement project, whether that would limit progression, which it wouldn't. And again, that's in the guidance. Okay, hopefully I haven't missed anything earlier on. So sorry, Tom, if you want to carry on.
No, I was thinking that I think that was a really good spread of questions there. So thank you everybody for submitting those questions. One question from me is if there are some further questions that people might have following this webinar or following watching the recording, where might be the best place for people to go for answers or for further guidance and support?
I think primarily we've presented a lot of information on the JRC PTB website. That would be the first documented area. But again, we can't overemphasize the interaction with trainer and trainee is of critical importance, always been important, but the further we get into internal medicine training especially, that interaction will be the single most important. If there are issues that people wish to discuss otherwise, they can contact us through the JRCPTV website. We will take in other questions if people want them answered, and we will be using the panel that has been presenting to make sure that you get adequate answers. There is, however, an FAQ series of questions about ARCP, which I believe is now up on the website, but I'm looking at Zoe. She was saying it was going to be up by the end of today.
Yes, they're already up there on the
Excellent.
COVID page.
Okay, so that's why I'm saying that's documented, but if there are other questions that come up, more than happy for people to contact us at JRCPTV or use the local offices so that you can get the answers that you need. We appreciate this is an incredibly difficult time for both trainers and trainees, and we want to provide as much support and help as we can.
Thank you, Mike, and thank you to all our panel today from me and from the audience. I think this has been a very rich and useful discussion. As I say, I apologise again for anybody who had difficulty at the beginning. This webinar was so popular that we seem to have crashed the system. The recording of this will be available soon on the JRCPTV website, along with the frequently asked questions and guidance documents that's been discussed. But thank you everyone for joining us today and taking the time to submit your really useful questions. And I hope you all have a very enjoyable rest of your evening.